tumors, and you can't, sample each section and do it in frozen because the patient is under anesthesia. They also have to give you report in 30 to 40 minutes. They can't do everything. So probably they'll consider the most suspicious area or the solid component. So a carcinoma in that focus can be missed. So there is always a very high likelihood of a mucinous, a benign going to borderline going to malignant, or vice versa. So that has always to be considered in such patients. So that you have to remember among all the ovarian tumors. Mucinous are the most tricky on frozen that way.
Okay, sir.
So with omental, what you will do? Infracolic or total omentectomy? You have these there,
Extent of your surgery. Just explain in one line what all procedures will you do for her.
So, infracolic omentectomy only, sir.
Okay.
But when involved, which situation? What are the indications of doing total omentectomy, and what are the indications for doing infracolic omentectomy in a patient with malignancy, epithelial ovarian malignancy?
Ma'am, if it is malignant, then we'll do the total omentectomy.
Now, see, there is a tumor inside the omentum, right? You
Yes,
can see there's a deposit inside the omentum. Size is maybe 1 centimeter, maybe 2 centimeter, maybe larger. So in that situation, when there's a tumor there, you have to do a total omentectomy actually. Infracolic omentectomy is done for the purpose of staging when you don't find any obvious gross disease in the omentum.
Yeah.
Right?
Okay, ma'am.
So these are the two differences in when you do infracolic versus total omentectomy.
Total omentectomy. Yeah.
Okay. What
Yes,
what else will you do? Okay, you did total omentectomy. Fine.
Will examine for the pelvic and para-aortic lymph nodes, and if they are found enlarged, we'll do lymphadenectomy.
If they're not enlarged, then they could see there's a fallacy here. Okay, we are going into a very difficult situation where we are saying the tumor is borderline, but then we are finding a mental metastasis. Right. So let's make it clear now. Let us make it more clear. Otherwise, it's all going to be confusing. So if they suppose the frozen section says a mucinous adenocarcinoma.
Yes,
all right.
Yes, ma'am.
So that's the of your surgery, and there's a no mental meds. Now you'll be more clear. Okay. Then we'll come to the borderline also later.
So, ma'am, then we'll do the lymphadenectomy, ma'am.
Extent of your lymph node dissection.
Up to the renal vessels in case of pelvic and para-aortic lymph node will dissect, and up to the renal vessels and inferior mesenteric artery, I guess.
What do you mean? Both you cannot be. I mean, you are going up to renal vein. That's it. Right?
Yes, ma'am. Yes, ma'am.
Now let's come to the next step. So what else? You said you did omentectomy, you did pelvic para-aortic lymph node dissection. Anything else you would do? What are you missing?
Cytology, yes. And ma'am, you have told appendix, you have told that it was normal, so we'll not remove that. It is normal,
so you will not do it. Very good.
Yes, ma'am.
What about peritoneum?
Ma'am, we'll take up the intraperitoneal biopsies during the surgical staging only, ma'am.
Okay, do multiple peritoneal biopsies.
Yes, ma'am, multiple peritoneal biopsies.
And if there are any abnormal areas, you will do the biopsy from those abnormal areas as well.
Yes, ma'am.
Now, one more thing is here, but there are two things which I would like to ask you. Tell me, what is the possibility of the lymph node involvement? What is the possibility of lymph node involvement in this patient? Probable chances of positivity. She's mucinous adenocarcinoma. Grossly, clinically looks advanced, right? Stage 3, maybe 3B.
Okay, ma'am.
In 3B, she's stage 3B or 3C. There's a lymph node. Will you do a lymph node dissection? That's one thing. You have to understand that. And you have to tell me what is the probability of her having lymph node involvement.
There's a high probability of involvement of the lymph nodes and the both para-aortic and the pelvic lymph nodes.
Now there are two things here. One is
Yes, ma'am.
that when there's a mucinous adenocarcinoma, there are two variants of mucinous adenocarcinoma. Can you tell us that? Can you name those two variants? What are they?
It's a pattern on histology.
Yeah,
Due
based
to
on histology. So lymph nodal involvement, the extent of nodal involvement depends on that type. Which subtype is that? Can you name those subtypes of mucinous adenocarcinoma? There are two subtypes, expansile and infiltrated.
okay, ma'am.
So
Yes, ma'am.
expansile, the risk of nodal involvement is lower, 2 to 3%, and in infiltrated, it is 30 to 40%. Okay.
Yes, ma'am.
So since already the disease is already in the omentum, she's stage 3B or 3C, depending on the size of this. Will you still do a lymph node dissection? That's my question from you. You cannot make out whether she's expansile or infiltrative. That's for sure at this stage. It's really difficult. You cannot make out. Pathologists will never tell you. So based on that,
yeah.
which trial and what should come to your mind now?
So is there a difference between when you are staging the lymph nodes in early cases versus advanced cases is what Dr. Seema wants to ask you, is there a difference between, and there is a trial which is a very good trial, prospective trial, which has given, good answers on that front, early versus grossly advanced, because of course you don't have the histopathology intraoperatively. So, anything which you, any difference between the kind of whether you do systematic lymphadenectomy in cases of advanced or not?
Have you heard of Lions trial?
No, ma'am.
Okay.
Probably they have second year OBG, so I don't think so.
Doesn't matter. Doesn't matter. Doesn't matter. It's okay.
Yeah.
It's all right. See, what happens is whenever there's a early stage disease confined to the ovary, okay,
Yes,
or
ma'am.
maybe pelvis. So in those patients, you will do a systematic lymph node dissection in epithelial ovarian cancers. Why? Because there's a chance that most of them, almost 45 to 55% of them would upstage if we do a lymph node dissection. Upstage to stage 3A. Okay.
Yes, ma'am.
So that would have a direct impact on their prognosis. However, the patients where there was an advanced disease means where the omentum was involved already, stage 3B or 3C. In those patients, doing lymph node dissection versus doing no lymph node dissection. There was a randomized trial which proved that even doing a systematic lymphadenectomy, there was no benefit of OS to the patients. Overall survival did not improve. Rather, the morbidities were more of doing lymphadenectomy. And that is why in epithelial ovarian cancers, whenever the disease is advanced, lymphadenectomy is really usually not required. You don't have to do it. Is that clear?
Yes, ma'am. Thank you, ma'am.
That's clear. So you will do an exploration. You will find the enlarged nodes. If they are enlarged, you will remove them.
Okay, ma'am.
Okay. And now regarding the fertility preservation also, when the disease is so much advanced, it is already involving omentum, right? So in those
Yes, ma'am.
patients, sparing the other ovary and the uterus is also a cause of concern because the chances of relapse are really high and the recommendation for fertility preservation is really poor in these patients. Fertility preservation in epithelial ovarian cancer, any stage, any pathology, is usually recommended up till stage 1C, 1 max. Am I right, Dr. Modi?
Yeah,
Or would you have
perfect.
some?
Yeah.
So in this particular patient, having fertility preservation also will be a concern if it is malignancy. Is that clear, Nikhil?
Yes, ma'am.
I
On
think the
yeah.
only thing which you can add there is, Nikhil, whenever you are counseling the patient, that's why, intraoperative counseling, I was asking you, if, for example, the frozen would have told you borderline, then you have to counsel that probably in the sitting we are not removing, because in borderline you can go for fertility sparing to a bit of more higher stages also in certain patients. But then you have to counsel patients about two things. So one is that they should be willing for a two-step procedure, that if in the final histology, if it comes to be adeno-CA, they have to go for completion surgery. And for example, if she's advanced, and if in the final report it comes as borderline stage 3, she completes her family and then she has to complete the surgery. So this they have to agree on before you actually, because advanced borderline tumors, fertility sparing is still very controversial. So that's why, and especially mucinous tumors, as Dr. Seema has also told, are heterogeneous kind of tumors. So, you don't, even the pathologist can't predict. So these reports can change. So counseling of these patients is very important, especially unmarried females with, parents having concern about their fertility, because it should not come as a shock to them when the final reports comes as adeno-CA. They have to be, somewhat prepared whenever it is mucinous. So that is very important with
That's
these.
very nice, very nice. So now the next aspect is, Nikhil, that suppose you opened this patient and there was no disease in omentum, no disease was there, and there was a tumor confined to the ovary, some small solid area. You sent it for frozen. It is now borderline ovarian tumor. Do you understand now the new situation for you?
Yes, ma'am.
So now what will you do? What will be the extent of your surgery? Forget about the mental meds, nothing now. Clean abdomen. Now tell us, what will you do?
In this case, we'll do a fertility preserving surgery, ma'am.
Right. So what will be the extent of your surgery? Tell us. How will you proceed? Patient is lying in front of you. Tell me, how will you proceed for her?
Ma'am, we'll do unilateral salpingo-oophorectomy.
Very
And
nice.
then we will do omentectomy, ma'am, in
So
case of
wait. You have removed the tumor, right? There's
Yes,
a tumor there. You remove it. And then what will you do with that tumor before you proceed with the intracoelic omentectomy?
We'll send for frozen, ma'am.
Yeah, you will open it or not? Would you not
Yes,
like to
ma'am.
see what is inside, right? You will
Yes,
check
ma'am.
inside
Yes,
the tube also, and you can send it to frozen, and from there also you can see. Sometimes pathologists may not like to open up the masses. It's all right. So you will open up the mass, you will check inside. Are there any solid area? Are there any papillary excrescences? What is the status inside? And then you will send it for frozen section. And based on
yes,
that
ma'am.
report, now the report is borderline ovarian tumor. So
Yes,
what will
ma'am.
you do now? What is the extent of surgery now for you?
Ma'am, we'll do the infracoelic omentectomy, and then we'll look for if there are any mets in the peritoneum or diaphragm, or lymph nodes are palpable or not.
So they're not.
Appendix.
You will not say it is mets. You will say, are there any abnormal or suspicious areas? Because it is a borderline, probably the borderline tumor, right?
Okay. Yes,
These are
ma'am.
invasive. There's no area of invasion there.
Yes, ma'am.
Superficial, less than 3 millimeter area of invasion. So they are the ones which do not behave like proper malignant, right?
Yes, ma'am.
These tumors, fertility preservation is the ideal choice. Okay.
Yes, ma'am. Yes, ma'am.
And then, so in these patients, the only thing which makes a difference in the outcome is two things. One, tumor should not rupture. Second thing will be complete peritoneal staging. So a peritoneal staging would require, as you said, infracoelic omentectomy and multiple peritoneal biopsies.
Biopsies. Yes, ma'am.
Will you do a routine lymphadenectomy now for her or not?
Ma'am, it can be done, but it is the later the complications are there, ma'am. That may
No,
lead
it's
to a
not required. It's not
Yes, ma'am.
required, Nikhil.
Okay.
Borderline tumors, lymphadenectomy does not pose any benefit in the survival, okay, or recurrence.
Yes, ma'am.
So it's not required. Okay.
Yes, ma'am.
Is that fine? Dr. Modi, any questions from you?
Yeah, Nikhil, suppose I change the scenario, the similar case, you open the abdomen, there is a mass on one side, you have a few omental deposits, and you send this, mass for frozen section, and it comes out to be yolk sac tumor. What do you do next? You have done a scan before, and
Yes, sir.
there were no enlarged nodes as such. And, now what? These omental deposits were also not seen on your scan before. So what do you do now with this patient? And how do you counsel also?
So we will give them chemotherapy as the germ cells tumor are
No.
sensitive.
But the patient is open in front of you. You have sent the mass. The report has come to be probably germ cell tumor, probably yolk sac, or mixed germ cell tumor. What do you do next now for this patient? The patient is open in front of you. You see a few omental deposits, no deposits on peritoneum. But what do you do? CT scan didn't show, or whatever investigation you did upfront didn't show any nodes, and you have already examined, opening the retroperitoneal spaces that, I cannot feel any enlarged nodes. So what you do for this patient?
So in this case also, then we'll do unilateral salpingo-oophorectomy.
Okay.
And afterwards we'll give chemotherapy. So
okay.
No, see, when they are germ cell tumor, think of the extent of surgery, what all you are supposed to do. Sir is asking you another clinical situation so that you understand the management of each type of adnexal mass in this particular patient. It's a useful exercise for you. So just think about it. Just think afresh. Forget about the previous situation. It is a yolk sac tumor. So what will be the extent of surgery with yolk sac tumors? Very simple question, Nikhil. Just think, you're right. Just think about it again.
You have to just think about whether they are chemosensitive, do they have good prognosis? What do you do?
They are chemosensitive, so
they are chemosensitive. So what do you, what do you do? So the patient is open in front of you. Uterus and other ovary is normal. You have few omental deposits. Okay.
So adjuvant chemotherapy only.
Yeah. Okay, so you remove the ovary and you will not address the omentum. In this case, what you will do? Only remove the involved omentum, or you will do a total omentectomy?
So, most probably the involved omentum only.
Okay, involved omentum only. Nodes?
No, sir. Nodes will not remove the lymph nodes. So.
Okay. So that should be good enough, I think, Dr. Seema.
Yeah, should be good enough. Nice. So you answered it well. So you have to basically, the take home for you will be during evaluation. You have to always be careful. You have to take all the preoperative measures, including ultrasound, including imaging, and including tumor markers, to clearly discriminate between benign versus malignant, so that you can appropriately counsel the patient and your family. Right? Because fertility preservation remains a very, very important aspect of management of adnexal masses in younger women. Right? And while during surgery also, frozen section has a very important role. So you should always have your pathologist on board. You have to discuss with them the case beforehand, so that they are aware that how appropriate they need to report this patient. Okay. And then thinking, removing everything in every patient is not the way. And you have to know what are the various indications where you can safely preserve the fertility. Right?
Yes.
Not all tumors are chemosensitive. Germ cell tumors definitely are highly chemosensitive. Cure rates are very good. Fertility preservation is the standard of therapy. For epithelial malignancies, whatever it is, till they are early confined disease, you can do fertility preservation. But for advanced diseases, fertility preservation is dangerous because risk of recurrence are very high, and the patient's outcome will not remain curative then. Okay, so that you have to always understand. Dr. Modi, from your side, I think.
Yeah, I think I also will summarize on the same front as Dr. Seema has done. So I think, Nikhil, it is very important to understand that fertility sparing is not the standard of care. It is just a deviation which you are taking because the patient is unmarried and probably has ambition of fertility. So in these cases, you are taking that risk after counseling, that you have to tell the relatives and everything that this is not the standard procedure. This you would not do in a postmenopausal female or in a female who has completed her fertility. For that, in those cases, you would go for the standard of care of whatever as per the type the tumor is. So this is a deviation. And in this germ cells, leaving germ cell, because there is no specific guideline of completion surgery for these tumors, other tumors like borderline or stage 1A, 1B, 1C, where even in epithelial, you have to counsel them that they have to undergo a completion surgery whenever they are done with the thing of fertility. So this is one thing which is important. And
Yes,
anything you want to add, Dr. Seema, for
Yeah,
this?
another aspect we can add like is chemosensitivity. You have
Yeah.
to remember that chemosensitivity, leaving disease on for the chemosensitive nature of the disease, you can do it in germ cell tumors. You don't have to be really very much radical for the germ cell tumors because they are highly chemosensitive tumors, respond very well to chemotherapy.
Yeah.
So be conservative for those patients.
Yeah.
But when it comes to low-grade serous cancer, low-grade endometrioid tumors, mucinous tumors, these are not very chemosensitive tumors. The rates are very low, 20 to 30% patients only would respond to chemotherapy, rest will not. So don't leave disease for the chemotherapy to act. Remove as much, everything as, as that's what is indicated. And for high-grade serous cancers also, if they are there, then fertility preservation, in my opinion, doesn't work for them, these patients. And, you have to be really radical. But yes, high-grade serous cancers are chemosensitive. And remember, for the epithelial ovarian cancers, a genetic testing is essential when these patients
yes, ma'am.
are at younger age. So having a good family history, pedigree chart, genetic counseling, and going in for genetic testing and giving them maintenance therapy will help them to, kind of have a better PFS.
Okay.
Dr.
Thank you, ma'am.
Dr. Mala, your comments, please.
Yeah. It has been a very great session. And I'm sure all the PGs have really benefited from your and Dr. Rahul Modi's deliberation. Your guidance has been great, Dr. Seema. We are very happy that you joined us.
Thank you.
And for all the PGs, the day has been great, interactive session. And they have really gained from today's deliberation.
Yes.
Thank you. Thank you for the opportunity, ma'am. Thank
Yeah,
you.
yeah. I think we can have
And Nikhil,
more
you were
sessions in
wonderful.
the
Yeah.
Yes, ma'am.
You were great.
We
It's very difficult to answer like that, and you
Yeah.
really worked well. Very well done. Keep it up.
Yeah.
Very well done.
Definitely. I think it was the most tricky of all the
Yeah,
parts,
it was
at
difficult.
this level. Yeah.
We grilled
Definitely.
you a lot, baby. We really grilled you.
no
Oh,
issues, ma'am. I learned a
from
lot
all
from
the
you,
PGs,
both of them.
yeah, from all the PGs, I thank all the moderators and all the PGs who actively participated in the case presentations today. And I'm sure tomorrow again, we have a long session of lectures. And I'm sure all the PGs, especially the exam going PGs, will have a great time tomorrow. And they will have a learning also tomorrow. Thanks, everyone. I thank all the PGs who have delegates who have joined today and all the moderators who have guided our PGs. Thanks, everyone.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Okay,
Bye.
bye-bye.
Bye. Thank you.